Good afternoon, ladies and gentlemen. Thank you for joining us this Friday, the 26th of September, for yet again another EMS Eco session here with us. And today, we're going to discuss the approach to a child with severe respiratory distress. And with us, we have a team of experts. So we welcome you. These sessions are bi-weekly and organized by the Ministry of Health of Uganda, Emergency Medical Service ECHO project with support from SEED Global. We are glad that we celebrated our 100th session 2 weeks ago, and this is our 101st EMS ECHO session. We are glad that many of you have joined in, and we are yet to hit another milestone. We pray that you keep us with us. So today, the journey is going to include actually sharing knowledge on the history, essential history for a patient with severe respiratory distress. We'll also look at the essential clinical assessment, and we'll also look at the relevant laboratory and imaging investigations done. We'll also look at the acute care management for a child with severe respiratory distress. And then within the same session, we want to know the acute care predisposition plan. So you're all welcome. And to start it off, as many are joining us, this session will include a case presentation. We'll have experts elaborating more. That's from the nursing team and also from our pediatrician. And again, through this session, we have polls that you'll be seeing online. We urge you to respond. You'll be having a few minutes, probably 1 or 2, to respond. So please be alert. And to start it off, the moderator today, Dr. Enoch Sebunya, a medical officer at Caris Medical Chanja. And I'm going to allow the experts to introduce themselves. We're going to have it in a clockwise manner. And I'm going to start with my colleague on the right. Please, you're welcome, Dr. Joseph.
Thank you so much. You're welcome all. Good afternoon, ladies and gentlemen. My name is Dr. Joseph Sigwe. I'm emergency medicine resident at Makerere College of Sciences. I'm honored to be part of this. Thank you.
Thank you, Dr. Joseph. And on my left.
Good afternoon, ladies and gentlemen. My name is Michael Stephen. I am a pediatrician, currently in the pediatric IC of Mulago National Referral Hospital.
Good afternoon, ladies and gentlemen. I'm glad to be in this place also today. I'm by the name of Olobo Peris, a pediatric nurse at Ginger Regional Referral Hospital. Thank you.
Good afternoon, ladies and gentlemen. I'm Mary Juliet Nampao, pediatric anesthesiologist at Mulago National Referral Hospital.
Oh, thank you very much. You're almost welcome, our experts and the audience. We see many have logged in. We've already actually 100 and more yet to join us. This session, we're going to begin with the case presentation, but before that, we would love to hear from you what you expect from us. Remember, we've had sessions a little similar to this, but if we get no expectations, they will guide what the experts have to make sure you live with as knowledge and skill. So you feel free to post in the chats, but also if you wish to make your expectation heard, you're free to raise your hand and then we allow you to speak to us. So one who has joined in, please feel free to post in the chat, and then we shall get to know what you expect from us. And as you get to post your expectations in the chats, as we added earlier, so that please also expect pause at every point in this presentation. And those poll questions allow us to know your knowledge and also gauge your learning at the end of the session. So feel free to answer them at any point. They will be posted. In case you have an expectation that you need us to hear from you, you're welcome. Raise your hand and then you'll be allowed to speak. We'll allow 1 or 2. For those who are just joined in today, we are having a session where we'll be discussing approach to a child with respiratory distress. And as usual, we usually have a case upon which we base our discussion. And we will also have a presentation from the experts, the nurses, and then our expert, the pediatrician. So we just have a few minutes allowed again to those who wish to share with us the expectation for this session. Yes, Betty Nakauka, if you wish to, would love to hear from you, your expectation. And after that, Dr. Price Mwagaba, you'll be welcome to speak to us and we'll get to know your expectation. You are unmuted and can get to hear from you. And then in about 1 or 2 minutes, we'll be starting off with our case presentation. Yes, just read a few of the expectations in the chat. Derek Semambo wishes to know oxygen administration according to the severity. And then Mr. Muhammad Baruku wishes to know the vital signs to look out for during assessment. So for now, we'll go with that, and please keep your expectations posted in the chat. We shall go through them and they will guide our experts. So you're all welcome to this 101st echo session, which is about approach to a child with respiratory distress. And right now, we're going to go to the case presentation. And just remind us that within this case presentation, we'll be having polls posted, and please be ready for them. For now, Dr. Joseph, you're welcome to present.
Thank you so much, Mr. Moderator. Good afternoon once again. My name is Joseph Sigwe, and I will present a case of approach to a child with respiratory distress. And just in case, kindly pay attention. So this is MJ, 3-month-old female baby who was referred from Arua Regional Referral Hospital, who presented acute care unit Monago with the difficulty in breathing. It had been there for about 10 weeks. So the mother notes that the child got difficulty in breathing. Right away from birth, that was mild, so they were never given oxygen at birth. From delivery, so they were discharged home, but on the second week of baby's life, the difficulty in breathing came worse, and they were admitted at Arua Regional Hospital, and the difficulty in breathing became progressive, associated with occasional dry cough and difficulty in breastfeeding. Also associated with intercostal recessions, nasal flaring, and occasional bruise discoloration, where the child would disconnect itself from oxygen. Yes. So right away, we go for primary survey. So the air was patent and breathing. This baby was in respiratory distress at the respiratory rate of 62 breaths per minute. The chest was hyperresonant on the right, and the reduced air entry on the right, saturating as low as 81% on room air. In the saturation, it had warm peripheries. The catheter refill time was less than 2 seconds, but was tachycardic at 151 beats per minute. The heart sounds 1 and 2 were normal. There were no added sounds. There are no murmurs. And disability, the AVPU scale was up to V. TPOs were equal and relative to right, about 3 meters, and the random blood sugar was in the normal range. They had soft neck. The fontanelles were normotensive. There are no identifiable focal neurological deficits. Within the exposure, temperature was normal. There was no conjunctival para or cyanosis at the time, but had some dehydration. Yeah, from that short history and primary survey, what is the most imminent emergency in this patient if you are the one managing? What would you focus on from that very short history and short examination? So go ahead and tell us what we'll focus on, at least one imminent emergency.
Yes, so our poll at this point has been posted. So please feel free to read and then answer. And this is actually to help us assess your knowledge at this point, which we will use at the end of our session. These 4 questions will be repeated at the end of the session, but as for now, they just guide us to know what knowledge we have at this stage and what gaps we have to cover. At the same time, these very 4 questions actually guide our experts to know where to hit most in terms of imparting knowledge and skills to all of us. So feel free to answer those questions. And in about 2 minutes, we shall end the poll, but you have all the time for now to answer them. Question. And our poll question actually yearns to know our knowledge in terms of, from our history and primary survey, what actually is the imminent emergency. And after this, the expert will go ahead to continue with the presentation, for which we'll also get to know what the expert thinks is our imminent emergency. For now, we wish to know what yours is. And among those 4 options, we choose one as an answer, a single choice. So many have answered, and within a minute, we're going to end the poll and then continue with our presentation. Thank you. So we've kept your responses, and then for now, we can continue. Dr. Joseph, you're welcome again.
Yes, so at this point, we saw in the air where the air was patent, so that's normal and okay. So in breathing, we had respiratory distress. As if you can remember, we had respiratory rate of 62 breaths per minute and SpO2 of 81 on room air, hyperresonant chest on the right, and reduced air entry on the right. So if that is not addressed immediately, so we are at the risk of respiratory failure, and this baby can actually get neuromuscular fatigue, and worse still, if nothing is done, this baby is at the risk of getting hypoxic cardiac arrest. So it is respiratory distress that you have attended to at this point in time. So, having known that it is respiratory distress with that information that you've been given, what would you do at this time? Tell us what you think.
So indeed, our second poll now bases on what we've already confirmed as our imminent risk, which is the severe respiratory distress. Now we want to know that actually what would be your management option for this patient. We have still 4 options. You can choose one. This continues actually to just guide us on how knowledgeable you are, and that will again guide our experts. So filling that poll, again, we have 1 or 2 minutes to answer that. And thankfully, again, our expert will continue to present. For now, we wish to know your knowledge on what would be your management option for this patient with notable severe respiratory distress that has been seen in our primary survey. And for those actually that feel like they need to elaborate a bit more, the chats are also open for you, for your answers, for any queries, for any questions. We have Dr. Mary who will be responding to those. But as for now, let's complete that poll question, upon which the next actual presentation will be responding to that. For those who have any queries and they need any elaboration, or they need to give us any information, the chats are open, and we'll be responding. So in about a minute or so, we'll be also concluding this chat, this poll question. Many have answered, and many are yet to actually also answer. Okay, so thank you for responding to that actually poll question number 2. So Dr. Joseph, again, you're welcome to continue.
Yes, having seen that the child was in severe respiratory distress, the child was given oxygen therapy 2 liters per minute using nasal prongs, was positioned in same sitting position, and further supportive management continued taking off blood for investigation, finding out what really the case was. Yes, so we got what we call sample history. Sample history is a summary of history that one can take while doing this quick assessment. So signs and symptoms that the child came with were difficulty in breathing, use of accessory muscles of respiration, nasal flaring, and occasional deceleration whenever of oxygen, associated with chest indrawing and feeding difficulty. The child had no known allergies, and the medication that were on is pretty much oxygen therapy. The referral form had antibiotics that were not specified at the time. And in the past medical history, this baby was born well, vaginally. They did not get asphyxia at birth. So they were discharged home, but the mother kept on looking at the respiratory patterns that were not normal. In the second week of life, this baby was admitted at the Arua Regional Referral Hospital and was given oxygen therapy. Whenever we disconnect oxygen or reduce, so the child would become cyanotic. So the child was largely being treated for chronic pneumonia and bronchitis throughout, but not getting the improvement they were expecting. So they had to refer for further management. So notably also the mother and baby, they were HIV negative. So the last oral intake, they had breastfed about an hour prior admission. And the reason why they had to be admitted at the Monaco particularly is because they had a worsening difficulty in breathing despite being treated for pneumonia and bronchitis, and they needed further specialized care. Yes. From there, we go to head-to-toe examination, maybe system-wise, CNS, central nervous system, was largely normal, except for the AVPU equal to V, and the child was drowsy thereafter. In the cardiovascular system, the most significant finding was the tachycardia of 151 beats per minute, but the rest was okay. Respiratory system had issues, had asymmetrical chest with hyperresonant chest on the right, reduced air entry, and saturation low sats as low as 81 whenever there would be of oxygen. So the trachea was central on examination. But abdomen, the findings were largely unremarkable. Yes. So from this, a baby of 3 months with that severe respiratory distress being treated for pneumonia but not improving. So we start thinking of very many things. It could be this, it could be that. So we come what we call differential diagnosis. So infectious voice, so categorizing them be like, could it be pneumonia? Sorry for the typo there. So could it be pneumonia? Could it be bronchiolitis? Could it be that this baby had difficulty in feeding? Could it have aspirated during breastfeeding so that they have aspiration pneumonia? And these symptoms being that they started at the earlier phase of life, could they be congenital? So could we be having cyanotic or cyanotic heart disease? Could we be having congenital lung malformations? Or could we be having pro disorders like spontaneous pneumothorax, given the history of hyperresonant chest and reduced air entry on one side? Could it be that? Could it be asthma? So we're thinking very many things at the back of our mind. So the investigations continued. So we did a full blood count. The white blood count, the white blood cells were near the low one normal range, slightly low, with the relative monocytosis and basophils slightly raised. The hemoglobin was 11.7 grams per deciliter, which was in the normal range. Red blood cells were as the red count was as raised. Platelets were 216, which was in the normal range. Malaria blood smear, there were no malaria parasites C. The random blood sugar, as we had discussed earlier on, it was 5.1, which is in the normal range. The liver function tests were done, and the AST was slightly raised. ALT was in the normal range. ALP was raised. Total protein was slightly reduced. The electrolytes, sodium 136, potassium 4 in the normal range, chloride in the normal range. Creatinine and urea were largely normal. So we did get full questions to answers the questions we have. We did not rule out find out this diagnosis. So the blood findings were non-specific. So we move ahead to do further imaging. So due to reduced air entry on one side and hyperresonant chest, and chest is asymmetric and buried on the right. So we're thinking, could this be a spontaneous pneumothorax? So a long ultrasound was done, and our findings were normal findings, no pleural or pulmonary pathology, and no pneumothorax. So pneumothorax can be actually ruled out on ultrasound. So it could be congenital heart disease. Let's do cardiac echo. And those are the echo findings. There was mild tricuspid regurgitation with the right ventricular systolic pressure raising up to that of the systemic pressure, severe pulmonary hypertension, which was secondary to a primary lung disease. So that was the cardiologist report saying this severe pulmonary hypertension should be secondary to the primary lung disease. Went ahead to do chest X-ray, which was showing radiolucence on the right middle row with attenuated pulmonary saturation with spraying of ribs on the right. So I think still not getting full picture. So we went ahead to do a chest CT scan, and there it is. You can see. So what did you see? What can you identify as a pathology? At least there is a pathology that we shall see.
So indeed, based on so far the secondary survey and then the investigations that are done, as per now, we wish to know what you think about the images you see before you. And the images that have just been posted, or what you see right now, is actually a CT scan that was done for that child after all the rest of the other assessments being a little non-conclusive. But now we wish to get your knowledge. The chats are open. We'll read a few of your responses, probably one or two. What do you see? That's a CT scan of the child that was done during the investigation. Yes, so that's the chest CT scan of the child that was done. So we wish to know, what do you see? The chats are open. We know some of you actually have already picked the pathology, and we'll be glad to read your responses. We have 1 to 3 minutes, and we wish to know. And actually, also for those who wish to speak their mind, you can just raise your hand, and then we get to hear from you. So, but that's the chest CT scan of the 3-month-old, which was done during the assessment of a child who came in with a severe respiratory distress. We wish to know, what do you see in that chest CT scan? So Dr. Praise Nwagaba is seeing hypotensity, stroke air in the right lung, and he's also thinking of a cardiomegaly. That's Dr. Praise. And then Busura Mandi is saying left lung collapse. Thank you. And then Catherine Nandaula, she's seeing a cardiomegaly. J. Peter Erema is seeing a lung collapse. That's on the right, according to Erema. And then Amos Kusetula has a number of differentials, one being cardiomegaly, and number 2 being the right lower lung collapse, which is showed by the radiolucency of that lung zone in that area. Joyce N. Wamala, she thinks this is a left lung collapse. Atukunda Luke is seeing cardiomegaly and also seeing a right lung collapse. Then probably lastly, those also would have wished for anyone who wished to speak their mind, they can raise their hand. Muima is saying it's a pneumothorax on the right lung, and possibly saying it could be due to the birth injury. Medias Chakwaire is saying the heart is on the right side instead of the left. So all those are views of people how they are appreciating and what they see in the chest CT scan. Then we are seeing Chirabo saying it's a cardiomegaly. Mukasa Joseph is saying the left lung is the one that's collapsed with compensatory hyperinflation on the right. Ronald Elema is saying it's a pneumotocele. That's air in the cavity. Then Rogers Matani is saying there's a pleural effusion in the right lung. So as we see all these views, we now, I believe, can go to the next step to see what was actually the right interpretation of this chest CT scan. Dr. Joseph, you're welcome again. Go back.
Slide. Yeah, from the interpretation of the chest CT, there was a right hyperradiolucency on the right middle lobe that was causing a collapse of the right middle lobe. Right lower, the middle lobe was hyperinflated, leading to collapse of the right lower and upper lobes. The hem diaphragms were flattened, and the shift on the diasternum to the right. So there was no cardiomegaly, and the left lung groups were largely normal. So that led the conclusion of
Yes, we can go to the poll question. So as we've seen, many of us had very many views in regards to the chest CT scan we've posted. The expert has given us a clue in terms of the reading, but now we again bring it back to you in that poll question. What is the interpretation of the CT scan? We've seen very many views. We've also heard from the case presenter, but it has a diagnosis. So what is the interpretation of this CT scan that we've just seen of a 3-month-old who came in severe respiratory distress? The single choice, so you have only one option. And as we've seen in the chat, many people have very many different views, so we wish to know now in terms of clear knowledge assessment through the poll question, what you think is the right interpretation of this chest CT scan. So continue to answer that poll question. We just have a minute or so to conclude that. And as we've seen in the chat, many people have different views. Some are saying cardiomegaly, others saying a pleural effusion, others saying actually it's the left lung that is collapsed, others the right. So many people have different views on what would be the right interpretation of this chest CT scan of a 3-month-old with severe respiratory distress after previous admissions and treatment for different conditions, and especially it was pneumonia, the bronchiolitis. So in a minute, we'll be concluding our poll question. So for those who have not yet answered, please do. And actually, this is where we get to learn that chest CT scan can have different interpretations. Thankfully, we have experts on board who get to hear what the interpretation is. So thank you for all those who have responded. And Dr. Joseph, you're now welcome to continue.
Yes. So we had those are the findings: congenital right middle lobar emphysema, compression atelectasis on the right upper and lower lobes, and severe pulmonary hypertension, secondary to pulmonary lung disease. But for the purposes of clarity, I would go back to the CT images, and I try explaining a few findings here and there. So if you look at the CT images before you, you can look that actually at least the second last row, you can see that actually the left lung is actually not collapsed. Maybe the third image there, you can see that actually it's not collapsed. Of course, CT is taken in different angles, so if you just use one slice, you can actually misinterpret it. But if you look at the different slices and you add up all the findings together, you can see that left lung is not collapsed. Still on the same image, you can see that on the right, there is increased radiolucency. So that too much black, it is air infiltration. And keep in mind that actually, we had already ruled out the pneumothorax using lung ultrasound, and even in this, the air itself is not within the pleural space, it's within the lung itself. So there is hyperinflation of the right middle lobe. So slightly above the black, there is a piece of lung so that is the upper lobe. You can see it on the first row there. So you see that the upper lobe is there, but it is of a smaller size than it's supposed to be. So it is slightly collapsed, and the lower lobe is actually collapsed almost. The lower lobe, yeah. The lower lobe under the black are finding the lobe is all collapsed. So the heart, if you see it from different images, is actually, apart from being displaced to the left, itself it is not enlarged per se. So one would not call that a big cardiomegaly, but there is a general mediastenosis to the left. So the hemidiaphragms, both the left and the right, they are all more flattened than they are exposed to be. So generally speaking, you can see that there is too much air in the right middle lobe that is compressing on the upper lobe and the lower lobe, leading to their collapse. Then mediastenosis to the left and collapse of main flattening of both hemidiaphragms. So we come up with the conclusion of congenital lobar emphysema. So it is a congenital disease whereby there is a hyperinflation of the air in one of the lobes, and that air is causing collapse of other lungs, hence affecting the lungs that are supposed to be actually taking oxygen in the body. So a child will end up with respiratory distress. So that's all you should understand from this. So the pulmonary hypertension is a secondary complication of the emphysema itself. So because the lungs are filled with air and they are compressing on pulmonary vasculature, so the heart has to strain pump blood through the pulmonary artery. Yes. So having known all that science and looked at those nice images, so what are you imaging? What are your top 3 management options for this patient where you've known that there is a congenital lobar emphysema? So what would you do as the healthcare worker at that point?
Yes, so you're all welcome to respond to that poll question that needs to also gauge your knowledge based on what we've had as our primary survey, the history, and then secondary survey and the investigation, the last we've had, which is a chest CT scan. What will be your management priorities? The options are still 4 with one choice. Within 2 minutes to 3, would wish to know your knowledge. And actually, as we go to that, Dr. Joseph has a bit responded through his explanation to a number of questions that I'm seeing in the chat. For example, if we go to Muanguzi Calvin, who wondered that if the right lung is collapsed, yet your exam is saying hyperresonant on the right with the reduced entry, explained. So Dr. Joseph has already responded to that, that actually the right lung is not collapsed. It's just emphysema with complications of atelectasis of the right upper lobe and then the lower sagittate. So the right lung is not collapsed, and probably he did well to respond to all the queries in regards to the chest CT scan. And as we've noted, many people thought there was cardiomegaly, there was collapse of the left lung, collapse of the right, and we had another who thought it was actually pleural effusion, but we had good lung markings on the left with a reduction on the right. So thank you very much, Dr. Joseph. You've been elaborate in your explanation to the chest CT scan. So please, we may continue to complete our poll question, which wants to know what would be your top 3 management priorities option in this very patient. Remember, we are looking at a 3-month-old with severe respiratory distress, and so far we are thinking this is a congenital emphysema with complications of pulmonary hypertension. So what would be your management priorities in this very patient? For those who are responding, we have now just a minute. Conclude that poll question. Yeah, you can look through all those 4 options. And so far, based on our history, we had the primary and secondary survey with the sample history, and then the investigations that ended with us going to actually doing a chest CT scan for this 3-month-old. Okay, so. Thank you very much for all those who have responded to the poll. And Dr. Joseph, you're now welcome to continue.
Yes, thank you so much. So looking at the type of emergency that is before us, we have a 3-month-old baby with a severe respiratory distress caused by congenital lobar emphysema. So we've now gotten the diagnosis. But the definitive management of this diagnosis is more surgical. So you have to do supportive management as you consult units. So at this point, you position the baby in a semi-seated position. The affected, the non-affected lobe should be the one that is out. The affected one should be the one that's down to allow better expansion of the normal lung. Offer oxygen therapy. Now, targeting saturation between around 92 to 96, avoiding hyperoxia, that would not complicate the emphysema itself. This baby was nebulized with salbutamol because during the course of stay on ward, I think had wheezes, and the clinical team chose to nebulize with 2.5 milligrams of salbutamol. Then, given the fact that actually this baby had feeding difficulties, nasogastric tube was inserted, and then feeding still continued with the expressed breast milk. So at that point you see that this child was about 5 kilograms, feeding, giving around 100 to 150 mils per kilogram per day. So if the baby can actually be able to take all of it as expressed breast milk, that's better. But if they are intolerant to the fluid, to the feeds, then some of it has to be given as intravenous fluids, maybe ringers, dextrose. But if they are able to take it, all of it through the NG tube, the better. So you continue monitoring the saturations, then you do consultations to different teams. So this is a child. So the pediatric team is already in management. So now I have to consult the different teams that are needed to make sure that this child comes out with this. So a consult to cardiothoracic surgery was made, and I plan to do a lobectomy was made. So the pediatric anesthesia had to do pre-op assessment, and the pediatric pulmonology, then securing space in PQ, then the plan operative management. Yeah, so antibiotics were not given because the point of presentation, actually this baby did not have markers of infection and had been earlier on treated with antibiotics from the referring facility, but without much improvement. So the antibiotics at that point, they were not so much necessary, unless maybe an indication for them came on later on. So the patients from acute were taken to ward 16, then CDS took over, then from surgery, then had to be admitted to PQ. Not yet admitted to PQ.
Yeah. So thank you very much, Dr. Joseph. And here, at this point in time, actually, there are a few questions that are posted in the chat. For anyone who would actually wish to raise a question and you would wish to raise your hand, we'll actually give you a chance. You might give one or a maximum two. But for now, there's a question from Lule Colin, who's wondering that why the team at Mulago opted for a nasogastric tube instead of, according to this, actually, I think it means an orogastric tube. And and then another question, probably the expert in the next presentation will especially will elaborate more on this, on elevated bed with blocks at the top. Is looking at that as an option. And then on the same line, another is proposed it in this way, that how is the baby supposed to be positioned? Yeah, so all those questions are going to be responded to. For now, thankfully, our expert will elaborate on those questions. For now, let's go to the next presentation, which is actually the nursing emergency care for a child with severe respiratory distress. And Mr. Perez, you're welcome.
Thank you so much. I'm by the name of Perez, pediatric nurse. This is an interesting case to handle or to get on your table. Now, as a nursing team, when this case comes onto your table, you don't need to just bump onto it and then you start managing anyhow. We have to go through some process for you to come up with the right management that this child requires. I wanted us to just have some little introduction about respiratory distress. That it says it's a medical emergency where a child has a great difficulty in breathing due to impairment on the airway, lungs, or breathing muscles. It represents the advanced stage of respiratory difficulty, and if not recognized and quickly managed, can progress to the failure or death. So this can come about due to the injury, fluid, or exudate leaks in the air, leading to inadequate oxygen delivery, impaired removal of oxygen, like in adult. Children have a smaller airways, less respiratory muscles, reservoir, and high oxygen demand, making them more vulnerable to rapid deterioration once respiratory distress develops. I think that one put us in a quite view to see where we're going, why we have to manage this child, very fast and very critical point to see. So respiratory distress, they can come commonly through bronchitis, asthma, pneumonia, epiglottis, pulmonary emphysema, and other upper respiratory obstruction like the COPD, that is the chronic obstructive pulmonary disease, laryngotracheal bronchitis, that is the croup, the adenoid hypertrophy or enlarged adenoids, laryngeal papilloma, and the foreign body aspiration. So having all those ones in our mind will lead us to where we are going to start managing this child. What are our objectives for this? The objective for the presentation? One, to understand the causes, assessment techniques, and the nursing care for the severe respiratory distress. Two, to highlight the importance of timely response and collaborative care in improving the patient. I think all those ones that we have seen and put in mind will drive us to what to do for this child, because this child has been brought into our place. The nursing care plan, we begin with the assessment. On assessment, we have to look for nasal flaring in this child, tachycardia, chest retraction, and asymmetric chest. When this child bumps into your table, you have to see all those ones. The nasal flaring, that is the eager for this child, showing that there is a demand for more air in. Tachycardia, that is the fast breathing. Chest retraction is use of accessory muscle. It can be lower or upper or both of them. Asymmetric chest, we shall see that the chest, you have to see the symmetry of the chest. Are they normal? Or one side is up or the other side is down? It will tell us what to do during the management. Because once you have not seen this, then you will not give the right management to this child. So on the nursing diagnosis, after us seeing that one on this baby, there was our nursing diagnosis was ineffective breathing pattern related to airway obstruction, as evidenced by tachypnea, that is greater than 50 beats per minute, with the SpO2 of less than 90. Remember, on our SpO2 was around 81. Retraction, there was use of muscles. Asymmetry, when we are checking this child, we shall find out that one side, that is the affected side, is more elevated than the normal side. So it will drive us what to do. If we have a moment, it has driven us on what to do. We have discovered all those ones. Finally, the next on our management, our goal would be one, positioning this child in a Fowler's position. The Fowler's position is a position at around angle of 45, slightly raised. We have to maintain effective breathing and adequate oxygenation. The amount of oxygen we are giving to this child, it is a supportive one. We don't need, because once, remember, the lung has become like a balloon. Give you an example. It only allows in and doesn't allow out. So when we're giving the oxygen, we have to be so keen we have to keep monitoring this child after every 15 minutes. Because once you give too much of the oxygen, remember, we are adding in, we have already air which is not escaping. So we have to be careful on. So we start with 1 liter, then we keep on raising according to the situation. So on the intervention, Those ones were done. Of unified oxygen was given. The child was nursed in a fowler's position and continuous monitoring for within 15 minutes, every 15 minutes. So the rationale of our management was to improve oxygen saturation, to note any abnormality. And after those ones were being done, we were able to see that after 30 minutes, we were able to have the SpO2 of more than 94%. We continue. We go ahead on the assessment because we are moving step by step, the nursing assessment. On the assessment, found that this child is coughing, there is wheezing, but the wheezing is only on one side of the lobe, that is the affected lobe. It is not on both sides, as it is common in asthma or in grunting, in pneumonia, where it is localized in both lungs. We have grunting, and the grunting it's only on the side of affected lung. Then we have chest, that sound that is hyperresonance because of the air in the lung. But most of us, we don't always take time to follow this step to examine or to assess these stages. On the nursing diagnosis, after us seeing those ones, the nursing diagnosis was ineffective airway clearance related to airway related to, I think that's the typing error, air, and that is exuded, evidenced by poor oxygen saturation, that is lesser than SpO2 lesser than 90, wheezing, hyperresonance, chest. So on the intervention, or our goal was to maintain the airway and continuous monitoring of the vital sign. And the child was nursed in that position, monitored after every 15 minutes. So our evaluation, after 30 minutes, the child was having an improved the oxygen saturation of that, and respiratory rate was lower, was below 15 beats per minute. On nursing assessment, we found that there was cyanosis on this child. The child was restless, irritability, and then they lacked lethargy. Because of the child is not breastfeeding well, the feeding, all this one have to appear. Since the oxygen was not, because there was impaired oxygen saturation. The nursing diagnosis came in impaired gaseous exchange related to reduced lung incapacity, evidenced by cyanosis, SpO2 less than 90. On our goal to monitor the vital sign after every 15 minutes. On intervention, the vital signs were monitored. The rationale to check or to note any abnormal changes. We have lastly, the assessment, last assessment. I think it is the second last. That is a nursing assessment. We have weak circling, underweight, lethargy, on nursing, all this one comes because the child is not feeding well, because the child, because of the condition. We have imbalanced nutrition related to inability to feed, as evidenced by lethargy, low weight, weak suckling, bradypnea. Then on our goal, we have to pass the NG tube, to set IV line, and our goal is also to achieve adequate urine output of 1 ml per kg per hour. Our intervention, all these ones were done. IV line was put, NG tube was passed to feed the child, and the feeding 150 ml per kilogram body weight per day. On evaluation, a child demonstrated a normal urine output of 1 ml per kilogram body weight per hour, and alert within 24 hours. The last nursing assessment, because weak suckling, lethargic, all these, the weak suckling and lethargic, it brought anxiety. Our diagnosis came as anxiety related to fear of death, secondary to a disease process evidenced by the child weakness and the mother's verbalization. So our goal here is to reassure, to counsel the mother and nurse the child in a calm environment. Then this one have been done, the child nursed in a calm environment and the mother being reassured. After 30 minutes, the mother was calm. This is how we manage this child supportively as a nursing team.
So thank you so much, Mr. Perez, for that elaborate presentation on the nursing care for this child, a 3-month-old with severe respiratory distress. After this same approach is utilized for similar cases where you have your nursing diagnosis and your planned intervention based on your assessment, and always take care of the child in this case and the parent. So thank you very much, Mr. Perez. Next, we're actually going to hear from the expert, Dr. Michael, who is going to present now the emergency department management of a child with severe respiratory distress. You're welcome.
Right. Thank you so much, the previous presenters. Once again, my name is Michael. I'm a pediatrician in the pediatric IC in Malago National Referral Hospital. We want to talk about emergency department management of a child with severe respiratory distress. As we go down this presentation, we'll probably look at a few other conditions that basically bring a child to hospital when they have severe respiratory distress. Part of it will be very much tailored to what my colleagues have been discussing. And every now and then we shall be trying to discuss it in line with this particular patient that we had. Just to throw some context, much of this information was gotten from a file. So we basically told you what happened in the emergency department, hoping to learn from that going forward. So a brief introduction. All these medical emergencies require a systemic approach, systemic and priority-based approach, so that we can all be reliable and have good outcomes. In any emergency setting, there are 4 sequential steps. These basically apply to all age groups. When a patient walks in as a clinician, you're going to have a first observational assessment, a very quick look without even touching them. And then you go to their primary assessment, which most of us know as a ABCDE approach. And then after that, you go to the secondary assessment and then the tertiary assessment, which basically has labs and imaging. And Dr. Ahimbisiwe basically went through those assessments for our child. Next slide, please. So the quick assessment, please note that any clinician can do this without even touching the child. Abbreviated as a 3Bs, you're basically looking at the behavior of the child, which will describe their muscle tone and mental status. Do they have any spontaneous movement? Are they able to sit or stand? Are they alert? Is there a weak cry? You can also see their breathing, okay? And I believe for this particular child, that's why it is in red. For this particular child, it was evident. They had nasal flaring, they had chest retractions. Sometimes you can hear abnormal sounds, any form of irregular breathing that you can notice, that can easily be seen. And then for some cases, you can actually have an idea using their body color. Are they pale? Do they have cyanosis, which our child had, or do they have mottling? So these three are seen even before you touch the child. And then you cross over to the primary assessment. There are lots of questions in the chat that are pointing, that are asking about what we mean by positioning. I hope they will be answered here. Basically in the airway, and please note we are talking about any child with severe respiratory distress, okay? So in the airway, we basically look and listen and feel. So you want to look in that airway. If there is anything that is obstructing it, take it out. If you listen and you're hearing any funny sounds, deal with them. The feeling is to actually tell if there is air getting in and getting out, okay? And usually we're going to have two types of airways in this case. Is it patent or it's not patent and probably at risk? If a patient comes in and they're able to talk and you can feel air moving in the mouth, over the mouth and nose, and sometimes you can see the chest, rising up, then most probably that airway is patent. But then if they come and they have a reduced level of consciousness, our child had an AVPU scale of V, or sometimes you can hear stridor or gargling sounds, then most probably that airway is not patent. So when you talk about positioning that airway, when we talk about positioning that Dr. Izwe was talking about, it's basically one of the maneuvers to open that airway. And for these little children, I didn't write it, but you can just leave them in the neutral position, okay? You do not want to overly flex them or bend that neck because you're going to block that airway. For the bigger children, that is when you can do the head tilt or the chin lift. Sometimes you can do the jaw thrust. Unfortunately, I don't have images for these, but they are very easily accessible over the internet. So that is what we basically mean by positioning. And this is for a child who has reduced level of consciousness. If the child is alert, they will position their airway in the best position for them to actually keep it open. So you don't have to force them into a particular position. If you hear any sounds like there are secretions in there, please suction them out. I'm looking at any normal emergency setting. Use whatever you have. Some people have suction machines, bulbs, syringes. Heck, we have sometimes just gotten gauze and tried to wipe out mucus. So anything that works to get that mucus out or secretions out, please do that. If you have oropharyngeal airways and nasopharyngeal airways, you can use them because they will keep that airway open. But please note, a child who is conscious will probably not allow them. You might cause them to gag more and they produce just more mucus and then you block their airways. So if you're going to use those, especially for the oropharyngeal, they had better be semi-conscious. The nasopharyngeal is two-way. Some of them accept, some do not accept. And again, I apologize, I don't have images for that. Next slide. So that was the airway. Basically, the slides are what you can find and what you do about it, okay? And in this particular child, I think for the airway, we didn't have to suction, but we just positioned them, okay? Now we go over to breathing. When you're assessing the breathing, you're basically assessing for four things, okay? You want to see if they're oxygenating, that is getting in oxygen. and ventilating, getting carbon dioxide out. One is the respiratory rate. Familiarize yourself with the normal rates for different age groups, okay? Number two is the work of breathing. Now, work of breathing is what most people call respiratory distress or use of accessory muscles. And these you can see on a child. Intercostal recessions, subcostal recessions, nasal flaring. Some tiny babies can actually have head bobbing or even wheezing that is audible. All those are signs of increased work of breathing. The other bit is termed as tidal volume, and that is when you get your stethoscope out, okay? If you auscultate and they have air entry, then probably they're making enough tidal volume. This particular patient did not have air entry on the right, so most probably their tidal volumes were not enough. That is a brief indicator that the air entering is not enough for your particular weight. And then the last one is a pulse oximetry. We kept on talking about them desaturating to 81%. So those are the 4 parameters that you assess for when you're assessing breathing. And please note, yes, continue. So if these parameters are not assessed as a one-off, okay, there are a series of measurements. As a clinician, if these parameters are changing, most probably going down without you making an intervention, please do not be happy for your patient. So if you have a respiratory rate of ours came with 62, after 30 minutes of you doing nothing, it has dropped to 40, your patient is not improving, okay? If they seem like they're getting normal without you having an intervention, your patient is actually decompensating. You should run, okay? So what interventions do we have for a patient who's probably having a high respiratory rate, increased work of breathing, tidal volumes are not enough, you're not hearing sound somewhere, and a low SpO2? First and foremost, and I think we all got it right on the poll question, is supplemental oxygen. There was another question of how much oxygen do you give, okay? So supplemental oxygen, I believe all of us non-nasal prongs, we can use nasal prongs, okay? Nasal prongs will raise your SpO2, your FiO2 by a maximum of about 16 to 20%, okay? So if you have nasal prongs, the best you're going to give on nasal prongs is 4 liters per minute. If those 4 liters per minute are not giving you an SpO2 of above 94%, then switch to the next higher stage, okay? High flow nasal cannulas are not so common, but if you have them, you can use them. Bubble oil electric CPAP, especially for the small babies, and if you need some sort of PEEP, okay, the positive end expiratory pressure, then you can do CPAP, okay? Especially for the tiny children. Our child was not grunting, but if they are grunting, then CPAP would actually help them. The next thing all of us know is a simple oxygen mask. If you don't have an oxygen mask, then you can actually do a reservoir, an oxygen mask with a reservoir that people usually call the non-breather mask. So those ones give you capability of providing a lot higher FiO2 than the nasal prong. Someone had asked about that question, because a simple oxygen mask can push the simple oxygen mask can push you all the way to 60% FiO2, and the non-rebreather mask can actually push you to about 90% if you're giving 15 liters per minute, okay? All right. Just previous slide, I think I missed something. Good. So beyond that, so that is for a patient if you see that they're actually able to breathe on their own and they have enough tidal volumes. Sometimes your patients are not breathing, and giving them oxygen will not help if there is no air getting in. That is when we begin the bag and mask ventilation. And this should not delay. If you're not seeing the chest rise, if it's not rising, just start bagging that patient. Lucky enough, our patient was breathing, so we did need the bag and mask ventilation. Sometimes we go all the way to tube them if you think you're going to be doing that bag and mask ventilation for long. If you can, monitor pulse oximetry. If you can, monitor the end tidal carbon dioxide for your patients. All right, we move ahead. So that was A and B, which were very pertinent to the patient we discussed, but are still pertinent to all patients that have severe respiratory distress. Now, the C is basically assessing for shock or any arrhythmias if you have the ECG monitors, but you can monitor for shock, the circulation of this patient. And there are basically 5 core things that we look at. What is the pulse rate, the patient? What is the peripheral perfusion? Do you have a cup refill time? Is it increased or it is normal? Do they have a temperature gradient, what people usually call cold extremities? What is the volume of the pulse that you felt? And then you want to look at the preload. These are actually abbreviated as the 5 Ps. But the preload is basically if you think this patient is in shock because of heart condition, where they'll probably have engorged neck veins and hepatomegaly. And then we also look at the blood pressure, okay? You can also listen to these heart sounds, especially if you want to know if this shock is basically due to the heart itself. And the last one I said is the ECG. The first 5 things can be done by any clinician, okay? And this will help you know where you're basically headed. Our patient, I think, had a tachycardia. Other than that, the cup refill was okay. The heart sounds were fine, okay? Yes, they had cyanosis, so we had to talk about the circulation because a problem in circulation can also appear as cyanosis. And then D, we also talked about disability for this patient. AVPU scale is a lot faster than the GCS. And our patient was at V. You look at the pupils, if they're reactive to light, and you also look at the random blood sugar, which was normal for this patient. Next. So E is the last one, and we also went through this. Dr. Ambis went through the AMPO, the acronym for getting very quick history in the primary survey, and also helps you to see any other thing on this patient that can give you a clue into the condition they have. We had no fever, we had no rashes, we had no signs of trauma. Let's go ahead, please. Okay, so that is basically the quick survey for any patient that has severe respiratory distress. You want to look at their airway. If there's a problem, correct it. Look at their breathing. If there's a problem, correct it. And the level of correction that you got depends on what the patient has, that's number one, and what your facility has, okay? And then you go to circulation, you go to disability, and then you also go to environment, which is E. So going forward, I want us to look at the most common conditions that we see in the emergency department that might come up with a child that has severe respiratory distress. We are going to keep it to emergency department, okay? So we do not have things of pathophysiology and epidemiology and the definitive management into the science. It's basically what you do in the acute care setting for any hospital that you're in. So quickly, severe pneumonia is lung parenchyma and alveolar inflammation, and can also come up with consolidation. Basically has pathogens that invade the alveoli and can give you exudates and collapse. Severe pneumonia was part of the differential diagnosis for this patient that came in. Respiratory rate was high, they had nasal flaring, couldn't hear sounds on one side. So pneumonia is part of the differential diagnosis. And this particular child had been treated several times on antibiotics for pneumonia. So let us look at the airway of a child with pneumonia. It might be at risk only if that child has reduced level of consciousness. Other than that, most cases, their airway is going to be open, okay? For this particular child, our airway was at risk because their AVPU was at V. And so how do we intervene in terms of the airway? If that child is conscious, let them take on their preferred position, okay? They want to be on the mother's lap, they feel comfortable, less agitated, leave them there. They want to lie down, let them take on the preferred position, okay? And try to avoid agitation, because when you agitate them, you increase their oxygen demands, you're going to worsen their work of breathing. But for the unconscious child, that is when we say open that air, what most people are calling the positioning, okay? So a neutral position for the infants, head tilt or the sniffing position for the slightly bigger children. If there is anything in that airway, like secretions, suction them out. These are the things that we talked about when we were dealing with the airway in the first slides, and then the oropharyngeal airways and the nasopharyngeal airways. Let's continue. And then in the breathing, this is a child with severe pneumonia. They're probably going to have an increased respiratory rate. They'll have increased work of breathing. You can see the subcostal or intercostal recessions, nasal flaring, head bobbing. Depending on the severity of their pneumonia, they might have reduced tidal volume, which will be evidenced by inadequate or upset air entry, like we had on the right side here, or sometimes you're going to hear abnormal breath sounds, broncho breathing here, crackles there, and most probably that SpO2 is going to be low. So that means that you need to intervene in their breathing. If they're still breathing and they're not working so hard, give them supplemental oxygen as per the demands that they have. You have nasoprongs, you can progress to a face mask. For the tiny ones who are grunting, you can give them CPAP. You can do a non-rebreather mask. And if it is so bad and their work of breathing is not so raised, but just literally no work of breathing, okay? The child is not breathing. The child is, you don't see any chest movements. That is when you come in with the bag and mask ventilation. Mechanical ventilation is in very few centers, okay? But most of us are usually going to stop at the bag and mask ventilation. But in places where you can vent this child and you start, you put them in an ICU so you can have oxygenation and ventilation happening. And like I said, for all these conditions, for a child of pneumonia, you don't stop at airway and breathing. Please follow through with the circulation. Our particular child had a tachycardia, okay? But other than that, there was nothing else. They were not in shock. We didn't need a fluid bolus. All we needed were maintenance fluids. We took off samples if they look pale, so you can have a level of HB. Basically, that is what we did for the circulation. Their disability, AVPU scale was at V. They cannot feed on their own. Insert an NG tube, start their feeding. But if they are alert, why do you have to fix an NG tube in them? Unless the work of breathing is so bad that you think they cannot feed normally, okay? Exposure, do they have a fever? Treat that. And is there any other clue that can give you an idea of what they're dealing with? That is when they all come in, okay? Other than that, usually in severe pneumonia, it's going to be the airway, it's going to be the breathing. The very sick ones will take you all the way to E, okay? So that is severe pneumonia. Can we continue? All right, so disposition plan. Dr. Ibisiwe talked about these. We talked about the labs that we're going to do. These only come in once you've sorted out the A, B, C, D, and E. And if you've been in an emergency setting, that can happen in as little as, what, the first 2 to 5 minutes. You've actually sorted out that patient. And that is when we come to the disposition. So the labs, I'm glad that we have done labs for this patient. We did a CBC. If you can do the acute phase reactants, CRP, procalcitonin, please do them. If you can do the blood cultures, you're thinking of antibiotics or infectious causes, please do that. In places where you can do PCR panels, please do those, okay? Most of us can actually get a chest X-ray. It should be usually the first investigation in radiography for children that have severe pneumonia. Please have that done because it will show you what is happening within the lung field. If you can do a chest ultrasound scan like we did, or a chest CT scan that we did. The CT scan definitely gives you a lot more answers. And I think we can see that from the patient that we had. Now, basically, these investigations give you a disposition plan once you have sorted out the emergency for this particular patient. And then they will let you know what you're supposed to do after that, okay? I put a slide of the non-severe pneumonia a bullet there. Nowadays, you can actually send them back home on oral amoxicillin. It is the severe ones that we are talking about, okay? Do we need to admit them? Yes. Do we need antibiotics? Yes. This particular patient, we actually started antibiotics because we didn't get the CT scan on day one. So as of day one, we were dealing with a pneumonia, so we did antibiotics. And if you have any complications, then other teams come in, okay? And in tertiary places, you will need surgeons, a CTS team. You're going to need a pediatric critical care team, pediatric anesthesia. Heck, you're going to need physiotherapy later. You basically need a team depending on the diagnosis and complications that you found out in that patient of pneumonia. Okay, so just to recap, any patient of severe pneumonia, basically is going to be the airway and the breathing and maybe the circulation that are going to be an issue when they come in. Unless they are very sick, then you run through the entire A, B, C, D, and E. Next slide, please. So most of these patients, review them in 48 to 72 hours. But if they're not improving in 48 hours, then you probably want to switch your antibiotics if you think it is actually infectious. Or reevaluate them for complications, just like we did for our patient. So empyema, bronchiectasis, emphysemas, iatrogenic pneumothoraxes, all those are possible and could be the reason that child is not worsening. Or you have a secondary diagnosis on top of the pneumonia, right? So that's it for pneumonia. Let's go to our next one. I also wanted us to talk about croup, laryngotracheal bronchitis. It's basically a clinical syndrome of inspiratory stridor and barking cough, hoarseness, and respiratory distress. For any of us that have seen croup, this patient will walk in and the entire hospital will know. If they are coughing, it is a heavy cough. Every person in there will turn to look at this particular patient. So how do we assess them? And for this one, we're basically going to talk about their airway and their breathing, because this can also be a child that walks in with severe respiratory distress. Their airway, if they're coughing like that, a barking cough, you can hear a stridor, their airway is at risk. Usually because there is marked swelling in the larynx and the trachea. So they are going to come up with that barking cough, they might have a stridor, and you can hear hoarseness in their voice. So their airway is at risk. Even if they are looking like you and they are alert, their airway is at risk. And what intervention do we do for this particular patient? Avoid agitation, because that agitation usually worsens the airway swelling and you put their airway more at risk. That is if they are conscious, okay? But if they're unconscious, any child who is unconscious has an airway that is at risk. So open that airway with the maneuvers that we talked about, depending on their age. And sometimes their airway is so much at risk that right there and then you need advanced airway management. If you have the skills, the techniques, all the cadres to do that, please let them know. Or sometimes that decision is supposed to be made as fast as possible. So the things that you can do to lessen the swelling in that airway is basically start them on a steroid. And we usually prefer the oral steroids. Why? Because the pricks are going to agitate this child more, okay? You're there fighting for cannula, please find a line, please find a line. The child is crying, you're agitating them more and their airway is just getting more at risk. So if you can get oral dexamethasone, please start that, okay? And then you nebulize them with adrenaline. Now, these are not your typical airway interventions because we are talking about croup, okay? You've not seen me say get an oropharyngeal airway or the nasopharyngeal airway. They will not help. If you want to put anything down that throat, it had better be an endotracheal tube. And that is supposed to be done by people that have expertise in that. But you can always give dexamethasone and nebulize with adrenaline, right? Next slide, please. In most cases, their breathing, the breathing of a child with croup is going to be affected mostly because of what is happening up in the airway, okay? There might not be any infectious pathology down in their lungs, but they will have an increased respiratory rate, an increased work of breathing. They will have reduced tidal volume because the entry to the lungs, that is the airway, has been closed off, and their SpO2 is going to be low. So give them 100% supplemental oxygen. That is delivered by a non-rebreather mask with a reservoir bag on it, okay? And if it is so bad and that air was closed up, they are not breathing, please start the bag and mask ventilation, okay? If you've put in a tube and they're still not breathing, continue ventilating them manually until you can do the mechanical ventilation. And also, like I said, in pneumonia, you still follow through for the C and D and E. Croup usually has problems up in the airway without any pathologies down in the lungs. Let's continue. Most of them, because croup is viral, most of them actually improve in about 1 hour, 2 hours, but please do not send them home right away, okay? Observe them, because whatever triggered might happen again before they go home. So for about 2 to 4 hours before you send them home. Rarely do we need radiology for them, okay? But if you need to admit them, then admit them usually for the airway protection and supporting their breathing. Those are for the very bad ones that probably needed intubation, or you think this airway can still close up, okay? And those ones will need their continued nebulization and steroids. Forward, please. Acute asthma exacerbation. Once again, these are very short because we're basically looking at different diagnoses that can cause a child to have acute respiratory distress. I believe most of us have seen a child that has asthma, okay? A heterogeneous disease that is characterized by chronic airway inflammation, airway hyperresponsiveness, and airflow limitations. And these exacerbations can be mild, moderate, severe, or actually life-threatening. Usually when they come to hospital, they are threatened. So it might look mild to you, but to that patient, it is actually life-threatening to them. And we can read through and see which one is mild, which one is moderate, which one is severe, or which one is life-threatening. In most cases, if they are alert, like I said, for children of asthma, their airway is going to be intact, okay, and not at risk. But if that asthma exacerbation is severe or life-threatening, some of them come in drowsy, some of them come in with an AVPU scale of less than A. Those are the ones whose airway you want to open. If there are secretions, there's a plus or minus, suction those secretions out, okay? And if you need to position their airways to be effective and keep them open, please do that. But usually a child of asthma, if they're alert, will actually pick on a position. They usually stoop forward. They want to sit because that is when they have maximum lung capacity and lung volumes. Do not force them to lie down on your nicely laid bed. If the child wants to sit, let the child sit, okay? You can do your interventions in that position unless they are unconscious. That is when you as a clinician give them a position that is optimizing their airway. Can you go forward, please? A child of asthma, most of their problems are going to be in the breathing, okay? Yes, they will have an increased respiratory rate. It will keep on worsening depending on the severity, okay? They also have increased work of breathing. These ones, you can actually see accessory muscles, nasal flaring, head bobbing. But sometimes if it is so bad, you are going to look at their chest and it's basically not moving. That is the life-threatening. If you get your stethoscope, you're most probably going to have wheezes, that's number one, or reduced air entry in the bases. And if it is life-threatening, you put a steth on and you think your steth is not working because you're not hearing anything down those lungs. That is actually what we call a silent chest, and it is a life-threatening condition, okay? And most cases, especially for the moderate, severe, and life-threatening, their SpO2s are going to be low. The mild exacerbations might actually have normal SpO2s, okay? So the intervention in the breathing are by and large rotating around opening up those airways. And that is when we use the short-acting beta agonists. Most of us know salbutamol, okay? Fancy people will talk about albuterol, but for now, let us talk about Ventolin, salbutamol. It can be oxygen-driven. If you have enough oxygen, open it up and drive it with oxygen. Or use air. If you have your nebulizer, if you can, there are lots of videos out there of handmade nebulizers with 60 ml syringes or 50 ml syringes, all a metered dose inhaler, if you can use it. And the doses are written down for the children below 5 years and the children above 5 years. And those can be repeated up to 3 times. If that patient comes in with their metered dose inhaler before you get your salbutamol in, please use theirs, okay? About 4 to 10 puffs in 15 to 20 minutes, and you can repeat that times 3 doses. So that is basically the first intervention for children with asthma exacerbation. Forward, please. So still with a breathing intervention, they are going to need supplemental oxygen. And this oxygen you give them also depends on how bad their distress is. Do they just need nasoprongs? Do they need a face mask? Do they need a non-rebreather mask? That also matters, okay? We give them steroids because it reduces on this airway inflammation. The doses are up there. You can copy them. We usually want oral prednisolone, unless your patient cannot take orally, that is the AVPU scale less than A, okay? Then give them IV hydrocortisone. But for an alert child, there is hydrocortisone, IV medication, IV steroids are not more potent, and their time of action is not faster than oral medication. If they are alert, give them oral medication, okay? If they do not improve with the salbutamol first line, and you have hypertropia, then you can introduce it. It is also nebulized, okay? In most cases, if you get into hypertropia, please inform someone above you or inform a colleague that I have a child and the first line is not working, because we have seen them end up in ICU, where we shall do the IV salbutamol and things like algae magnesium sulfate. But in most cases, as a clinician, go back, please. As a clinician, go back again. As a clinician for an asthma child, if they are conscious, let them pick their preferred position. If they're unconscious, optimize their airway, and then quickly get to their breathing. Nebulize them. Get salbutamol in with whatever device that you have, okay? So that is it for, I think, asthma exacerbation. Let us see the disposition. Yes, in most cases in an emergency setting, I will not run to do a CBC unless I'm thinking there's an infectious cause. Most of them do not actually need antibiotics. Radiographs are not usually needed in the acute exacerbations, unless the thing just keeps on worsening and you're thinking probably it's a foreign body now that is giving us a wheeze. Then you can send for radiography, okay? But please, do not let them out of that emergency unit if you have not educated them about asthma. And as pediatricians, if the child is old enough, even if it is 5 years, in the simplest of terms, okay, educate them on what to do, okay? Educate their caregivers on the triggers, on the medication, and also the inhaler technique. It is very important so they do not come back to your hospital again in such a condition. And we usually try to educate just the caregivers. Talk to the children themselves, because at least they can avoid triggers, okay? And then you can review them. That is, if you've been able to discharge them there and then see them in about 7 to 14 days, basically to check at the education things that you told them and to reclassify their asthma, okay? Let's continue. This is the second last one. Let's talk about a child that has a foreign body airway obstruction, okay? All of us that have seen foreign bodies, sometimes the history is very clear. Or he was playing with a bead, he swallowed it, then started, having difficulty in breathing. Those are going to be the acute ones. Those will come to hospital, and their presentation is so vast that you can easily see it. But you're also going to have those that have foreign body in their airway that has stayed there for quite some time and has probably been treated as a pneumonia that is not going away, or a bronchiolitis, or asthma, okay? We shall see how to deal with those also. So airway assessment is basically, this is for the child that has that overt acute presentation with a foreign body down in their airway, okay? And in most cases, like I said, a patient that is able to talk to you, their airway is intact. Patient that is able to cough, okay, their airway is most probably intact. And if they have an effective cough, encourage them to cough it out, okay? encourage them to do what? To cough it out. And as a clinician, check if they're not deteriorating. The cough is becoming less effective or they're becoming drowsy, then they are not able to effectively cough it out. If they have stridor or they are gagging, those you can see, okay? If they are now starting to have lots of mucus, those you can see. And if a child has an ineffective cough, but they are cautious, see that? That child has an ineffective cough, but they are cautious. Those are the children that we run to have the back blows done, okay? They had better be cautious, okay? You're seeing them cough, but it is not so effective, but they are still cautious. Those are the ones that you help to have that airway, that foreign body dislodged. And you can see for the infants, we do the 5 back blows, alternate with the 5 chest thrusts. We do not do abdominal thrusts in the infants because of their liver, okay? You can easily injure that liver. So those ones, we do the chest thrusts, but abdominal thrusts for the bigger children, okay? Forward, please. Now, if the cough is ineffective and they're unconscious, okay, there is no point in you starting to hit their chest or do the abdominal thrusts for them. These are the ones that you quickly go to actual CPR, open that airway and try to give them the first 5 rescue breaths, okay? And then you start their chest compressions. The ratio is 30 compressions to 2 breaths. This is a patient you're certain has a foreign body down their airway. They're unconscious, okay? There's just no point in you starting to do the abdominal thrusts. Please, if you see the foreign body, try to remove it. But do not go in there blindly and you start sweeping a finger over and over again trying to remove it, because you might push it further down and becomes a lot more difficult for you to get out. You're probably going to do those compressions until you get more help coming to do a laryngoscopy for you or to transfer that child to a place that can do that, so they can have it removed either by suction or using the Magill forceps, okay? And these are now taking you to a probably tertiary institution where they can be done. Any place that has an anesthetist can actually try to do that, okay? The usual called bacilli in theater.